Dear participants, dear colleagues, welcome back after the short break. We will now continue our webinar. My name is Helge Gilja. I'm professor at Haukeland University Hospital and University of Bergen, also a senior consultant at Department of Internal Medicine. And I'm also chairing the National Center for Ultrasound in Gastroenterology. It is now my pleasure to talk about the new gastrointestinal guidelines. We call it GIUS, Gastrointestinal Ultrasound, and I will also include the information on CEUS. My disclosures are as following. You can read here, but my most important disclosure is actually that I love ultrasound, and I'm teaching ultrasound all over the world in underserved areas as well. And I use it for clinical purposes, both bedside and at our department wide over. So I'm a little bit skewed towards enjoying ultrasound for all clinical purposes. My agenda today is to talk about the principles of gastrointestinal ultrasound, a little bit on methodology, wall layer detection, how you can measure the wall thickness, and I will show also how CEUS is reported in the guidelines and show a few examples of CEUS of the bowels. However, I would leave a lot of the CEUS of bowels to the next speaker, as he will talk in depth about ultrasound in IBD and particularly Crohn's disease. The gastrointestinal landscape is a fascinating one. However, it faces a great challenge to imaging, and particularly to ultrasound imaging and contrast-enhanced ultrasound, because there are a lot of motility going on, peristaltic activity, and in some cases also air is obstructing a good view into the abdomen. But hopefully I will show you that you can really use ultrasound to the best of your patients in many cases. As a basis for my talk is the 7 different GIUS guidelines and review papers that we have produced over the last 7-8 years. We started back in 2014 with 20 experts from all over Europe, and we have now produced a variety of guidelines ranging from methodology and examination technique via IBD, perineal transrectal ultrasound, acute appendicitis and diverticulitis, celiac disease and rare disorders, intestinal emergency, and also functional disorders. Now I will, in this lecture, focus mostly on methodology and examination technique, but also show you some clinical examples. This was the first guideline we submitted about basics and examination techniques, and we have included 19 different recommendations in this paper. And as a kind of basis for what you do, is to use 2 different transducers at least. We use a curvilinear ordinary transducer in the frequency range 3.5 to 5 megahertz to get a good overview over the intestines, and particularly to scan deep in the pelvic area to look for the lower part of the sigmoid and the rectum. Then we change transducer and use a high frequency ultrasound transducer, typically in the range of 7 to 12 megahertz, in order to study the details of the bowel wall. And in a case like this, you can measure the bowel wall thickness quite nicely. And how do you do that actually? How do you measure the body wall thickness? We have a standard, and that is to measure from the outside of the proper muscle layer, through the proper muscle layer, through the submucosal layer, and then into this muscularis mucosa and the mucosal layer into the luminal interface. So this is the right way of measuring. And you may know that whenever the ultrasound transducers travel through a new wall layer, there is an interface echo created, always bright white. So it will add on to the white layer, submucosal layer, and you have to subtract it from the dark layers, the muscle layers and the mucosal layers. But otherwise, there is a perfect correlation between histology here, the 5 wall layers, and ultrasound. So be aware of that. So what is the thickness in the different parts of the GI tract? Actually, the thickness in most of the GI tract is very thin indeed. only between 1 and 2 millimeters in most of the GI tract. However, in the antrum and the rectum, we have a little bit thicker portion. So the GI tract, typically, we have a cutoff of 3 to 4 millimeters in this region. And of course, also the sphincters are thicker. But in the middle portion of the intestine, it's very thin indeed. So how do you perform an ultrasound of the intestines? Usually, as I commented, we start in the rectum with a low frequency probe, and then we change to a high frequency probe and move to the right fossa iliaca, where we can identify the appendix, the cecum, and the terminal ileum. However, the appendix, usually we can't see in more than 50% of cases in healthy controls. However, if you have diseases of the appendix or other parts of the intestines, this will lighten up and be much easier to observe with ultrasound. Flexures, you have to look for intercostally on both sides, and be also aware that the colon transversum crosses the abdomen at various levels, depending on the body habitus. So this is the starting point of the examination. We identify the iliac vessels, the psoas muscle, and then on top of that is usually the terminal ileum, as you can observe here, some mesenteric tissue with vessels, and also some segments in transverse sections. What about the small intestine? Well, we have 5 meters of small intestine, as you know, so it's really difficult to state that you have looked at all these loops indeed. But we scan in a systematic fashion, back and forth and up and down, trying to visualize as most of the small intestine as possible. It's like mowing the lawn. And you also have to use some probe pressure in order to improve visualization in the deeper parts. And you should look for signs of pathology. And I will show you these signs now. Here you can see a marked thickening of the anterior wall, and also a marked thickening of the posterior wall, some fluid inside in a patient with Crohn's stenosis. So what do you look for? Be aware of these signs of severe pathology. A pseudokidney sign is one, indicating that it looks like a kidney because you have a marked thickening of the wall around the lumen, and the lumen often contains air and debris and therefore are hypoechogenic. Also look for target lesions. If you get a transverse section of an intestinal segment, it might look like this when you have pathology. Each wall is enhanced, and altogether they are creating a kind of target lesion. Also look for obstruction and dilatation of the bowels. Here we have a marked dilatation of a bowel segment caused by this short stenosis here. And look here, very short stenosis leading to a marked dilatation. And this turned out to be a patient with Crohn's disease. You can also watch the course of obstruction by using the panorama technique, like in this case. Here you see the dilated portion of a small intestine caused by this stenosis here. And then you can also see some marked wall thickening as we move along to the valvular Berhini. However, the cecum and the ascending colon turn out to be normal in this patient. In our recommendation number 3 in the basic methodological paper, we state that Doppler imaging by color is very useful in order to evaluate the vascularity of a pathological bowel wall. Here you can see how the inflamed wall is really enhanced by color Doppler imaging. You can see lots of vascular activity, indicating that there is a high degree of inflammation in this segment. However, in this case, you observe much fewer vessels inside the thickened wall, both in the anterior and the posterior part. However, you can actually use Doppler also to see the fluid export, the fluid transport across a stenotic area. So in this case, we are enlightened to think that there is less inflammation and more fibrosis in this patient, and we could rather recommend the surgery to a patient like this. Regarding contrast-enhanced ultrasound, this is also useful for the bowels, and we can separate vascular from avascular intestinal or periintestinal lesions, including abscesses. And abscesses is probably the most important indication for using CEUS in the bowels, because you have a very fine detection of avascular tissue. Here you can see the enhancement, the complete enhancement in the bowel wall in this case. Regarding liver guidelines, this was the non-liver ones we emitted in 2011 by AFSUM, and this non-liver guidelines was the first ever where we reported the use of contrast agents for the bowels, and it has been cited very frequently now, over 1,000 times in Google Scholar. So it's a very important paper exploiting and expanding the use of contrast-enhanced ultrasound. And in these guidelines, we estimated 3 different major indications for using CEUS in the bowels. First, to evaluate disease activity in IBD, then to distinguish between fibrous and inflammatory strictures, to localize abscesses, and also the possibility to visualize fistulas and the roots of fistulas. I will not go into details on this now. That will be dealt with in the next lecture, so please stay tuned. We did an update of these guidelines published them in 2018, and these has also been frequently cited. And in these guidelines, we added 2 other recommendations among totally 74 different recommendations on how to use gastrointestinal and other applications of CEUS. And we can use it for tumor evaluation, and I'll show you one example of that. Roald in his lecture show you a GIST tumor, and this is transabdominal ultrasound of a GIST tumor in the antrum of the stomach, and you can see how it enhances very nicely in the arterial phase. And you could, of course, ask what is the meaning of showing this. And actually, it's important when you take biopsies to take biopsies from the right portion of the tumor. And as you can see here, there are no necrotic areas, so we can be liberal in taking biopsy from the whole segment of this tumor here. Abscess detection is probably the most important indication, and to detect abscesses, CEUS for GIUS is very, very sensitive. And I will show you one case. This was a male, 25 years, with Crohn's disease. He was admitted to Helge Hospital some years ago due to diarrhea, abdominal pain, weight loss, and fever. And his history were that he had Crohn for 2 years. And way back, he did an MRI, which showed terminal ileitis, but also a segment of a jejunal loop affected on the left side. And he was treated with adalimumab. Then he was admitted to the hospital, and they did a CT in order to look for abscesses and fistulas. However, in the report from radiology, they could observe inflammation of the jejunal loop here and here, but they could find no stenosis, no abscess in this patient. However, as the patient still had some fever, we were interested in also performing a CEUS examination. We didn't totally believe this CT examination. Here you can see a marked thickening of the jejunal segment. You can also see actually a short stenosis, which CT did not discover. But what really caused our attention was this area here. Could this be a fistula leading to an abscess, or what could that actually mean? So we injected contrast, and here is the B mode, here is the contrast image, and observe now how the arterial phase, we have a complete enhancement in the bowel wall, indicating severe inflammation. However, look at this portion here. There is a fistula from the wall leading into a black area indicating non-viable tissue. And we play the video further on. And as we turn the probe a little bit, we can follow a fistula route further on. And when we rotate the probe even more and into the depth of this region, we can see an abscess cavity here that was not discovered by CT. So adding contrast-enhanced ultrasound really makes bowel ultrasound much more sensitive to detect abscesses and fistula roots. And if you have suspicion of that, despite the negative CT, negative MR, don't hesitate to use contrast-enhanced ultrasound to look for these lesions. One other indication we included in our last update of the guidelines was bowel transplantation. This is a very advanced operation that is not performed in all hospitals, and in Bergen we do not perform this. We have to refer the patients to other centers, but there are data suggesting that you can use CEUS to evaluate the perfusion and vascularity to look for complication after intestinal transplantation. I will just show you another interesting video which really indicates how delicate structures you are able to view with ultrasound. This is contrast-enhanced ultrasound, and you can observe how individual bubbles and clusters of bubbles are penetrating the GI wall here in a patient with Crohn's disease from the mesentery. And with such details, these details you can never obtain with CT, MRI, or any other imaging methods. This is a sovereign capacity of contrast-enhanced ultrasound with high frequency. And of course, if there has been any area in this segment that was avascular, that would easily have been picked up on an examination like this. So, in summary, gastrointestinal ultrasound is a useful method to evaluate patients with digestive diseases. You should be aware of the pseudokidney sign and the target lesion as signs of severe pathology. Furthermore, wall thickness is an important marker of disease and also provides prognostic information. Apply color Doppler to assess vascularity of the wall, and you should also evaluate GI motility to provide hints of pathology, particularly in the acute cases. And contrast-enhanced ultrasound is an important add-on to GIUS, and in many cases that can lead you to the right diagnosis of the patient. And finally, I will lead your attention to the new ultrasound book that we have published from the World Federation of Ultrasound in Medicine and Biology. It is freely available at our website, wufum.org. You can read, you can download images and videos and use for your own presentation and your own learning. So that is something I really can advocate for. So with those words, thank you for your attention, and I'm happy to take questions if you have, or discuss issues around gastrointestinal ultrasound of bowels and CEUS of bowels. I see no questions in the Q&A box so far, but we have time for discussion and question if you like to post something. Roald, I see your face. Do you have a question?
Could you say something about in what situation would you find it very useful to have contrast in addition to Doppler, or is that is that when you get the patient that were referred acutely, or is it more in a follow-up setting?
Well, actually, it's in acute setting, it can be very useful. If you have a thick stenosis, for instance, if you add the contrast, you can, to a much certain degree, establish whether this is most likely a fibrous stenosis or an inflammatory stricture that could respond to anti-inflammatory treatment. If you find a very low influx of contrast agents in the arterial phase, that is predicting this is a more fibrous stenosis, and you could recommend the patient rather to undergo surgery. But I think all in all, abscesses is probably the most important indications. It's very sensitive, and as I showed in the example, even when CT and often MRI are negative, we still are able to detect abscesses and fistulas with ultrasound contrast enhanced examination. And particularly in the superficial abscesses, who are often small in size, this is highly sensitive and even better than CT and MRI. However, the limitations is in the deep pelvic region, where we have problems with the penetration of ultrasound. Then MRI is often better to image fistulas and abscesses.